I go back to the point that we kind of we spoke about and referred to, and really based on those 7 drugs that we have positive data for, and as you see, the field is getting very busy in regard to many other drugs per se, and it's not necessarily a point of preference, but I would like to ask the question from the perspective of patients come to you, Rich, and they say, you know what, I heard about this immunotherapy, I want it now. And how would you really now, especially with the approval, as we said, of Nivo and pembrolizumab in second line, would you really go to that? And short of clinical trial, of course, go for a checkpoint inhibitor first line, or is it a TKI per se?
You know, there's no data yet that shows using these drugs improves survival in any setting, right? And while we do have very provocative response, duration of disease control in second line, their approval is currently limited to second line therapy. So in the front line, really the go-to outside of a clinical trial is either sorafenib or lenvatinib. With that being said, right, and this is for unique cases, you know, now that we have all these drugs, and I'm sure we're going to talk about how we sequence all these drugs, you know, there are patients who we see who still fall into a gap, and this is outside of guidelines. These are patients who, in my opinion, are very sick, right? They have advanced liver cancer, and they need some big response, right? And there's some of these patients, and you know, we can talk about what they look like, but they have a big tumor burden, and if they aren't one of these people who has a dramatic response, they're probably going to die pretty quickly. They're not going to live long enough to get a TKI, then an IO second line, or a TKI and sequence 3 or 4 drugs. So I would be dishonest if I said I've never given an IO drug front line, but it's certainly the minority of patients. They're not proven, they're not labeled there. But we do it with the hope that they're one of those 15 to 20% of patients who have a significant response, because if they don't, they're going to probably succumb to their disease pretty quickly. And before this, these were maybe the patients at one point I wanted to have given chemotherapy instead of Nexavar because they needed a response.
Andrew, same question, but in a different setting. Of course, we all get excited about our data, and the question would be is, you have a patient on sorafenib first line. It happens, you know. Would you give pembro as second line, or would you rego first and then pembro? I.e., do you position the checkpoint inhibitors in any way, shape, or form?
So again, in 2019, I think when we make this type of decision, we still don't have a very clear guideline, I have to confess. But having said that, we have to take into consideration a few things. I think Richard mentioned about the tempo of the disease progression, the tumor burden, which I think probably would drive the clinical decision to a certain extent. So if I have a patient with explosive disease that actually requires immediate intervention, something that's really active to control the disease quickly, I probably will be more inclined to offer checkpoint inhibitor as a second line right away. But if I have a patient doing incredibly well on sorafenib for a prolonged period of time, just a few pulmonary nodules that changing in size by 0.5 centimeter, I think it's very reasonable to switch to the regorafenib, in my opinion. So again, you know, we have to take into the consideration of the individual patient, how they respond to sorafenib, and what's their tumor burden. And also, obviously, there are other variables that we'll take into consideration, including the alpha-fetoprotein level, things like that.
Fair. Katie, along the same line, if you recall, on the correlative studies that were done on the SHARP trial of sorafenib versus placebo that were reported several years after, there was an intriguing that patients who did not respond had in high AGF, which, as we know, could be related to CMET per se. From the cabozantinib standpoint, would you make an argument if a patient progressed on sorafenib, you'll go for the cabo based on this and some other facts, or would you rush directly the checkpoint inhibitors?
I think that's a great point about we don't fully understand how to sequence these drugs. I think I also would interject the the data we have from the Tivantinib study, which tells us that from the biomarker analyses of Tivantinib, not the study itself, but the data from the MEDOV HCC Tivantinib study, which showed that patients who had had prior sorafenib had higher tumor CMET levels than prior to sorafenib therapy, meaning that sorafenib exposure increased MET expression because it's a very plastic marker and can upregulate in response to certain other therapies, in this case, such as anti-angiogenic therapies. And so the rationale that you're alluding to is the question of, might a MET-targeted anti-angiogenic agent do better in succession directly after a TKI such as sorafenib rather than interrupted by a PD-1 inhibitor, based on the rationale that you mentioned of the HGF overexpression as a mechanism of resistance, maybe primary resistance, but also the potential for secondary resistance upregulated on the TKI therapy. So I think that is exactly the kind of study we need to be doing right now to understand, rather than flip-flopping just to try something different. I think our next generation of clinical trials needs to take, now that we have the luxury of 7 drugs to work with, to take rigorous samples, particularly non-invasive samples, as much as we can to try to understand how best to sequence drugs, because I do agree that there may be a mechanism of efficacy that depends on prior sequencing right after an anti-angiogenic agent like sorafenib, particularly for Cabo.
No, by all means, I totally agree. If anything, the sequence that we are seeing and clearly is evident and proven is, for example, sorafenib-rigo. The other one, which probably is inviting or at least intriguing to think of, is, for example, sorafenib followed by sorafenib followed by cabozantinib. And interestingly, that this cabozantinib can be even effective as a 3rd line per se. And interestingly, despite those sequences that we are seeing, ironically, when it comes to the checkpoint inhibitors, we really have no understanding yet where do they fit best. And this is something that hopefully from the studies that are currently ongoing, being the Nivo versus sorafenib in 1st line, as well as the ramucirumab versus placebo in 2nd line, will hopefully shed some light in regard to that setting.